Hi, this is Brian Kim. I'm going to share with you case number 283 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. And so this patient was referred from out of town. Actually, she was referred initially for an ACIOL posterior capsule rupture and pseudophakic bullous keratopathy. Thankfully, the cornea improved, but because I thought the ACIOL was contributing to some of her problems, I removed that lens and then did a sclerofixated Domani lens. And so she's doing well with this eye, but now it's time for the second eye. And it's quite a dense cataract. And anytime a patient has a complication with the first eye, I'm very wary it's going to tend to have problems and potentially lead to a complication. And so that's why I'm sharing this case with you and be able to describe what happens. So I'm using the cotton tip to steady the eye, and this is a corneal marker, which will help me to center incise the rexus. You can see it's quite a dense lens, and this is the left eye of the patient. And this patient's a little bit anxious because this is the good eye. The other eye is a little bit weaker due to all the issues that it's had. I make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. And I use a cotton tip throughout these maneuvers to help me control the eye as I make those maneuvers. Less unpredictability is better for surgery. This is intracameral epinephrine, and then some air into the anterior chamber. You can see that the red reflex was pretty bad on this case. And anytime a patient has a complication, I always want to hedge my bets. And so using trypan blue, I think, is wise in this case because you never know what's going to happen. If the first surgeon had a problem with their first surgery, then you got to believe there must be something about this patient's eye that led to that problem. Painting the anterior lens surface with the trypan blue, evacuating it with the dispersive viscoelastic endocoat. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. Keeping that cannula in the eye to control it during that maneuver, and then now for capsulorhexis. So this is the Moria microrhexis forceps. I puncture the center, pull down towards me, and then grabbing the right side of the tear, going around. And because I have that cannula, if anything happens, I can push more viscoelastic simultaneously. It also helps me to control the eye in case a patient starts to move. Of course, capsulorhexis is a really important step during phacoemulsification, and this is a time you want added control. I take the cannula out at this stage because the patient has a tendency to roll the eye towards the left of the screen. And so because of that, I was able to do the maneuvers without the cannula for the second half of the rhexis. Finishing off the rhexis. And this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally. Hard to see any wave because the lens is so dense. A little bit of bubble there. Decompress the bag. And the lens begins to spin here. Again, this is the Veritas phacoemulsification system. I normally start in the peristaltic quadrant mode. Well, in this case, because of this history of complication, I don't want to take any chances. So I switch to the sculpt mode. And I sculpt a little bit of trough in the middle. And I sensed that it wasn't terribly dense, so I didn't feel like I needed to do any more sculpting here. So now I place a chopper under the rhexis edge contra-incisionally, pull it towards the center, fracturing the lens from the terminal side, which is the terminal chop maneuver. I'm able to propagate that fracturing plane across the entire lens. I place the chopper under the right heminucleus, pulling it centrally toward the phagotip to fracture the lens. You can see here I'm just being very, very careful, making sure I'm aware of the anterior capsule, making sure I'm not too aggressive with my maneuvers. And again, all of that is because this patient had a history of complication, and so you want to tread lightly when you're dealing with these cases. And this certainly the last thing you want is patients traveling from far away with the expectation that the second eye will go better than the first. So I turn the lens 180 degrees, and I perform another terminal chop maneuver on the other side. And again, I'm being very ginger, very careful. And then perform another cross-chop maneuver, pulling the chopper under the other heminucleus, pulling it centrally toward the phaco-tip and fracturing the lens in half. So one of the things I'm noticing is this lens just doesn't want to come out of the bag. And so that could be why the surgeon had trouble with the first eye. And so I believe that the lens is just rather sticky, but I also think that this may have some zonulopathy. But you saw how the Veritas so easily was able to grab that first quadrant up just using aspiration and vacuum. I'm able to get excellent purchase and pulled it right up. And so that's one of the things I've noticed about this machine. Excellent grabbing power. I'm able to pull lens pieces up out of the bag without it slipping. That was one of my pet peeves with other technologies. When you try to grab pieces up, it would just slip off. And of course, I've developed a technique where I can use a chopper to pull the lens piece up out of the bag. But it's certainly a lot better and easier if I can just grab it with some vacuum and pull it up out of the bag. So I emulsified that first quadrant, and now going after the second quadrant using another cross-chop maneuver to break it up, and then again using some vacuum to grab that fragment up, and then performing more manual fracturing, crushing the lens between the instruments, and then emulsifying the lens pieces. Again, the endocoat's really a great dispersive viscoelastic. It coats the cornea very well, and so I don't feel bad about using ultrasonic energy in this context because of the excellent coating power of the dispersive viscoelastic. So grabbing another fragment, crushing it between the instruments with manual fracturing, and then emulsifying it. Gently turning the rest of the lens to get it in front of me. Again, I've removed probably 1/4 of the lens, sliding the chopper under the rhexis edge again, and fracturing the second heminucleus with another cross-chop maneuver. Performing another cross-chop maneuver, fracturing the lens. And because I'm able to place that chopper under the rhexis edge confidently, again, because of a lot of experience, having done this thousands of times, I have muscle memory and awareness and the proprioception to know where my hands are, where the instruments are. So I feel very confident and safe performing these maneuvers. Manual fracturing, in my mind, is kind of the next level of cataract surgery. If you're able to perform manual fracturing, then you don't have to rely on sculpting and cracking and doing all these maneuvers. Because remember, the lens is bigger than the diameter of the rhexis. And so you have to find ways to break it down so that you can start to emulsify it. And the best way is to be able to use your hands to manually fracture the lens pieces. So now that I'm able to fracture those pieces into smaller pieces, I'm able to grab it with some vacuum and then crushing it with some more manual forces, crushing the lens between the instruments, and then now that quadrant is gone. So this is the last quadrant, turning the lens, getting the chopper underneath the rhexis edge, crushing the lens between the instruments, grabbing that fragment up out of the bag with some vacuum. Again, excellent holding power. I've had no trampolining throughout this entire case, no post-occlusion surge. The chamber is rock steady, which is what you want. Excellent corneal coating ability of the viscoelastic. And again, using manual forces to crush the lens into smaller pieces, using my instruments, and then fluttering the foot pedal and emulsify the lens pieces. You can see all the dynamics of the fluidics on the right side of the screen, including my foot pedal, the fluid bottle height, aspiration vacuum, as well as the ultrasonic energy. And here, now that the endonucleus is gone, I'm very carefully removing the epinucleus and using foot pedal control to modulate, again, to minimize any risk to the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out by turning off infusion, and then going in with the INE handpiece. Again, I turn off infusion every time I go in and out of the eye. So once I go in, I turn on infusion, adjust the sleeve, and then I start subincisionally peeling the cortex from anterior to posterior. By peeling it from anterior to posterior, you just get a cleaner removal of the cortex. And by sweeping side to side, I feel like I have better control. It's better to grasp it and then just tease it out manually rather than relying on the high vacuum. Because if you have sudden loss of resistance, again, it's similar, not quite like post-occlusion surge, but the concept is similar in that once you remove that cortex with high vacuum, there's a sudden loss of resistance, and then you might eat the posterior capsule. And so I prefer to just tease, especially with a metal tip. I prefer to tease it manually and then press down on the pedal to tease the rest of it off. And that way, a combination of foot pedal control and manually peeling and pulling the INA handpiece away and tugging on the cortex that's stuck in the bag. And you can tell right away that this patient has some loose zonules as I'm trying to pull this material off. I'm just concerned about the zonules and the posterior capsule being floppy. And as I try to remove the rest of this lens, adherent lens material, I certainly don't want to grab the posterior capsule. And so that might be why the original surgeon had trouble, probably a combination of a dense cataract and some weak zonules. And I'm using a BSS cannula to pulse the subincisional area and along the right side. And I do that because it's harder for me to reach with the INA handpiece, again with coaxial technique. So I turn off infusion and then I push cohesive viscoelastic to fill the bag, and then I swap out with the Singer Coke sweeper. So I sweep first on the left side and then the right side. Removing the lens epithelial cells under the rexus edge. And then switching to the cohesive viscoelastic cannula, using the cannula to control the eye as I place the injector through the incision, and then pushing more viscoelastic as needed in case the viscoelastic burps out. And then I use that same cannula I had in my left hand, and then I tease off the haptics off the optic. To me, this is the most efficient way of dealing with the ZC-BU lens. The haptics tend to be stuck to the lens, and so this has been the way I do it now. The ZC-BU is actually quite stiff compared to other hydrophobic acrylic lenses, and so in that way, it's really nice in that regard because once it's in, it will stay in the bag, and so you can feel confident that both haptics are in the bag correctly. Removing the viscoelastic from underneath the lens, polishing under the rexus edge, and then remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, you can see that this viscoelastic, the dispersive viscoelastic, coats the cornea so well that it takes a little bit longer to remove that viscoelastic from the anterior chamber, but again has excellent coating power, and so you can feel very confident when you're emulsifying the lens pieces that you have excellent corneal endothelial protection. Again, this patient had quite a dense lens. I used trypan blue, and I saw that it was a little bit difficult to pull the lens pieces up out of the bag, probably due to the fact that this patient has a little bit of zonulopathy and a floppy posterior capsule. But because I'm using manual fracturing techniques and then using the chopper to hook lens pieces up out of the bag, plus this machine, the Veritas, has great holding power of lens pieces with the high vacuum and aspiration, I was able to remove this lens without any difficulty. Again, I saw some signs where I could understand how it could have been a challenging case, but thankfully this patient did well without any trouble. So again, leveraging manual fracturing techniques and concepts is very important, but also utilizing a machine that can work to your advantage. Excellent chamber stability with the Veritas, excellent corneal coating protection with the viscoelastic, and again, no post-occlusion surge, I'm able to remove the lens pieces up very easily with excellent purchasing power of this lens. I'm able to grab pieces up out of the bag without any trouble, and then efficient emulsification, and this patient did great. So I hope this was helpful to you, and I thank you for your attention.